It's a pleasure to be here, but it's always very hard to talk after AG. So we'll talk about these first-time dislocators. If we talk about this subject, it's maybe a economic problem, because if you say that you have to do surgery in any dislocation, it's going to cost a lot because it's the most unstable joint and the prevalence is very high. Most of the time, the incidence is more in the game and training, more male than female. But you only see in the emergency room one first dislocation for 3 recurrence. But anyhow, if you start to say we have to do surgery on each dislocation, this will have an economic issue for sure. What about the recurrence? There's some studies showing that after the first dislocation, if the patient is going to be a chronic case, it will be the next episode will be in the first 2 years. This study was published in an old study in the clinical orthopedics comparing 2 populations, but you see that after 2 years, most of the time, the patient who have no recurrences, there's no more recurrences after 2 years. For these recurrences, there are some intrinsic and intrinsic factors. Extrinsic factors. If the patient is young, for sure you will have recurrences. The study was made in Paris for patients than 15 years old and less, was 100% recurrence. So a young boy with a 14 years old with a recurrence, with a shoulder dislocations, you are sure he will make a second one. Type and level of the sports, of course, we have high-risk sports like judo and rugby in Paris are the most, or in France. These sports are, of course, very, very traumatic for the shoulders, and even some surgeons used to do in Paris Latarget for the first dislocation in these sports that asking to the shoulder something which is supraphysiologic. What about the energy of the initial traumatism? If the patient do the first injury playing rugby with having a guy which is 100 kilos falling on him, you might think he has normal ligaments, but if the first injury was just putting on his jacket, you might doubt that he has good ligaments. What about the intrinsic factors? This is the picture of AG about immobilizations. So AG will have to talk to us about the immobilization in external rotations. Do we really reduce the amount of dislocation if you put our patient in external rotation? Rehabilitation, I'm afraid to say that I don't know how we can really control the instability with rehabilitations, because in this position you don't have any muscle that will be able to control the anterior displacement of the head. All you can is you can limit the patient. The rehabilitation, the patient will not have a lot of external rotation, and still the subscap will be in the front, it can control the head. But if you are in this position, nothing will prevent the head from getting out of the joint. What about the spontaneous healing? Of course, some patients have spontaneous healing, but in this case, here, you see this is an acute case. The labrum is here. The labrum is here. This is the anterior part of the glenoid. It's an acute alpha lesions. This has no chance to come back on the original place. This will heal in this position. For the intrinsic factors, the Sachs lesions, no engaging lesions. Now, whether the off-track lesions, we should say this. We found out in our study that all lesions that are medial, oblique, and superior are more dangerous than the other one. A lesion which is medial, oblique, and superior is more dangerous than other lesions. Of course, if you lose part of the glenoid, this is even more risky than the Sachs lesions. Fracture of the greater tuberosity, no. In fact, patients with fracture of the greater tuberosity have less dislocation, less recurrence than the others. And the labral tears, we don't know really which one are dangerous or not. For sure, the acute alpha lesions will have recurrences. If your patient is more than 40 years old, it's an extracapsular dislocations with the cuff injury most of the time, sometimes lesions of the greater tuberosity and subscap tendon. And in these cases, we must admit that the rate of recurrence is lower than in the young population. For these young populations, these intracapsular dislocations, you have major soft tissue lesions with alpha lesions, Bankart lesions, lesions of the ligaments, and sometimes humeral avulsion, but the humeral avulsion of the ligaments is more in the overuse patient than in the acute injuries. So your patient is making a few dislocations. He can heal. Not all of them will be recurrent. But the recurrence might be different. It might be just other dislocation, or just subluxations, or just instability, just apprehension. But apprehension is a failure. For a volleyball player, one dislocation, if he has apprehension, he will have to stop. He will go playing soccer. Although now soccer players have to use their hands to fight on the field. So what is the natural history? This patient, they have one dislocation and they still have apprehensions. They have to change their sport level. They'll modify their sport. They will convert to an overhead sport, contact sport. They have to stop. They have to go to a sport without any contact, without any overhead. And you know there are some quality of life index dedicated to shoulder instability. And this is Sandy Kirkley who developed this course a few years ago. What about the initial lesions? Is it a severe problem to dislocate the shoulder? The answer is yes. There are many studies showing that shoulder dislocations is a big injury. I've done some shoulder arthroscopy. You see full of blood in the shoulder, and there's always a lot of injuries to soft tissues. This old study made by Taylor and Arciero on these young military guys, 63 cases, younger than 24, 61 Bankart lesions, agular lesions, 57 Hill-Sachs lesions, 6 slap lesions. Shoulder dislocation is a severe injury to the shoulder. This is an example of a case we had in our hospital, showing you all the injuries you see if you do arthroscopy in an acute case. This is the examples of the kind of injury you will see: labral tears, acute Hill-Sachs, acute ALPSA, and tear of the superior labrum. If you look at the conservative treatment, we don't have any prospective randomized study. We don't know exactly if we have to put the patient in external rotation, yes or no. AG will tell us about this. And for how long? We don't have any prospective study on rehabilitations. We are not sure that if you do rehabilitation on these patients, they do better. And I don't know how you can control anterior instability with proprioception of the shoulder in this position. If you feel like this with your finger, you feel the head of the humerus. There's nothing in front that can prevent the head from falling down. Of course, we have the study of Ovilius, and Ovilius is following the same cohort of patients, 250 patients almost, from 27 different hospitals, and patients from 12 years old to 40 years old. So, big range of age. In 52 cases, no recurrence. But if you look at the paper of Ovilius, no word on apprehension. So, at least 52 cases of no recurrence, so 48 failures. So he's inducing a treatment with a 48% rate of failure. Would you use any kind of treatment with a 48% rate of failure? 23% needed stabilizations, but 34% for people younger than 22 years old. So 1 out of 3 will need surgery. He said that 22% have a spontaneous healing, but we don't have in the papers the criteria of healings. No word on apprehensions. And he said that 20% of these patients had arthritis at 10 years. That means, remember, 12 to 40 years, there are patients between 22 to 50 with shoulder arthritis. We all know how it's difficult to treat shoulder arthritis. There was a study made in France by Gilles Vache and André Coudane at the soft cut, comparing Bankart and Latarjet procedures at 10 years in terms of loss of external rotation, recurrence, and arthritis. And the conclusion of the symposium was that the main problem was the severity of the instability, was the duration of instability before the surgery, the number of the recurrences that would make the difference in terms of loss of external rotation, recurrence, and arthritis. So the problem is not the surgery, the problem is the pathology. They also compared the results between Bankart, Latarjet, and arthroscopy at 5 years follow-up regarding the arthritis. The same results. There was the same amount of arthritis between the 3 types of surgeries, and it was related to the amount of recurrence before surgery. So the problem is how late you are with the pathology. So the idea of this treating the first time of dislocation is to treat laxity before instability. When you have a first-time dislocators, ligament is just detached. There is no plastic deformation. So there's some papers on arthroscopic treatments. The funny thing is that they show a recurrence rate between 10 to 30%, not 5%, 10 to 13% of failures. We did a study with the French Society of Diagnostic Arthroscopy looking at the pathologies, and we just decided with the French Society just to look inside the joint and do nothing. And we found a lot of lesions, and we found out that just by lavage of the joint and removal of the arthrosis, we had the less number of recurrences. There's few randomized studies, one by Sandy Kirkley comparing 40 cases, patient younger than 30 years old, with almost 3 years follow-up, comparing group with orthopedic treatment and surgical treatment, and the big difference, 47% versus 16%. We look at 16% of failures on a surgical group, which is something not as good as a chronic case, for acute case. But in this series, it was the old Kaspari technique for the repair. That might be a problem. But we see that sometimes the results of the acute treatment are not as good as the chronic case. So it might be so that we have some ligament we are not dealing with when we just do the Bankart repair. Bottoni did this series, and the better result than the Kirkley. It was almost the same, surgery versus surgery and rehabilitations, but with a high difference, and only 11% in the surgical group, compared to 75% in the chronic groups. This study was made by Saraglia just on conservative treatment. Quite a big number of patients with anterior instabilities. And all these patients had dislocation, 7 for loss of follow-up. And the recurrence rate, before 20 years old, 42% of failures with recurrence of these patients with a conservative treatment. That means they have chosen to use a treatment with a 40% failure rate. Would you use an antibiotic with a 40% failure rate? So the question is there, what do you want, 40% failure rate or 13% failure? If you do an arthroscopic treatment, we know that through arthroscopy, the complication is not that high. You can do outpatient surgery. It's not a very painful surgeries. You can have the question of just make a joint lavage. There's some study going on now on joint lavage. What about the treatment? Some surgeons are doing in some places open treatment. They don't do arthroscopic treatment, they do immediate latarget procedures. I think it's a bit too much because you are making the shoulder even more stable than before the injury. For the bony lesions, that's very important. I think this is a key point. If you have to make a good examination for dislocations, and we have to fix the fracture of the glenoid. And if you don't fix the fracture of the glenoid, this will be an inverted pearl later on. It is not a progressive erosion of the glenoid, it's a necrosis of the initial fractures. We don't see the increase of these lesions on the glenoid, it's just a necrosis of the initial fragments. So it's very important to fix this fracture of the glenoid when you see them. What about the Sachs lesions? We are all thinking that we should treat the acute Sachs lesions, but it's not that difficult, that easy to treat it. Some team are using now balloon, like kyphoplasty. They're putting balloon in the head and just expanding the balloon, trying to treat the acute Sachs lesion. I've tried to do this under arthroscopy as like a tibial plateau fractures. It was not that efficient, I can tell you, or we can graft them. But we should think about also treating the acute Sachs lesion. The initial injury can be very different. Can be just subluxation, can be dislocation, be just an injury. The patient is falling down, he has a dead arm syndrome, and that's all. But initially it was really a dislocation, but he didn't feel the shoulder went out, just pain and dead arm syndrome. And there's no correlation between the clinic and the lesions. It's amazing how you see patients with just one single accident, it just felt pain, and you see huge lesions inside the shoulder. So if you have any doubt with your patient, you don't think what's going on, I think you have to have good X-rays, but the best exam at this time is MRI. This was a case of a patient, and the MRI gives us the solution. MRI is a very good exam in acute cases to give you the answer for the lesions. Then there was another study, very interesting, made by the team of Lubovitch, looking at the cost effectiveness of treating patients with first-time dislocation. They use Markov model, something economic, nothing to do with surgeries. And they look at the non-operative outcomes, including success and recurrences. They look at the surgical outcomes, and they look at probability of the outcomes or regarding literatures, and the analysis between the patients, between male and females, 15 versus 25 and versus 35 years. And they found there was any economic relevance to fix them. If you do primary surgery, it is less costly and more effective for 15-year-old boys, 15-year-old girls, and 25-year-old men. So if you do this, you are saving money instead of waiting the patient to have 3 or 5 recurrences and then doing surgery. For 25-year-old women and 35-year-old men and women, more effective but more costly. It was very cost-effective. Globally, if you cost per quality adjust per life year, I mean, if the quality of life, you put the value on the quality of life with the Markov model. So the conclusion of this is that the primary arthroscopic stabilization was cost-effective for young men and 25 years old women. So I think for the indication, if you have a young guy, 25 years old, really traumatic with a true dislocation, you should give him the option at least. Explain him that it's a severe injury, there's a risk of dislocation, it's better to do surgery at the first time than after 4 or 5 episode dislocations. We should do this in the first 15 days before there's any plastic deformation. But what we see in the emergency room is more recurrence than first dislocations. Most of the people, when you tell them that dislocation is a problem, they look at you, he's totally full, this guy, it's just a short dislocation. And it's a practical problem. In our hospital, we have a big emergency room. We did only 15 cases in 3 years, without any recurrence, but only 15 cases in 3 years. So if you have a high-level and high-risk athletes, rugby players, I think the acute treatment is a solution for these guys. They can be out of the field for 4 months. When they come back, they want to be sure they have a stable shoulder. You should propose them surgeries, and we are doing this now in France. First dislocations in a high-level rugby player or judo player, we fix them at the first episode, with most of the time with arthroscopic surgery. And the other option, if it's a low-level patient, you can say, give him the option, or tell him if you have any problem within 2 years, either apprehension, subluxation, dislocation, you will need surgery. Thank you very much.